Hi class, this is your narrated lecture on glandular tissue. So glands secrete chemicals necessary for functioning within the body. So an example that we're most familiar with is the salivary glands. They secrete saliva to facilitate digestion, immunity, and self-cleansing in the oral cavity. So you all have practiced palpating many glands in your extraoral exam. You palpate the salivary glands, the parotid, the submandibular, and the sublingual, and you also palpate the thyroid gland. So what are we looking for when we examine these glands? We are looking for enlargement. We are looking for tenderness. We are looking for symmetry. We want the gland to be symmetrical on both sides. And we are also looking for any lumps or bumps. So generally a gland should feel soft and movable. So the glandular tissue we're talking about today is salivary, thyroid, parathyroid, thymus, and lacrimal. So a gland is a structure that produces a chemical secretion necessary for normal body function. So there are exocrine glands, and these are glands that have a duct that bring the secretion to the area in which it is needed. So a perfect example is a salivary gland. All the salivary glands have a duct that releases saliva into the oral cavity. Endocrine glands are glands that have no ducts. That means that their chemical is secreted directly into the bloodstream to have an effect on the body. So what do we know about saliva? Saliva is a clear fluid secreted by an exocrine gland located in the head and neck, which empties into the oral cavity. You'll learn in histology about the microscopic composition of salivary glands, but they have acini that are clustered together and are secreted through various levels of ducts. So the composition of saliva includes water, electrolytes, mucus, and enzymes, and that can vary based on the patient's health, what time of day it is, what they're eating, and so on. So the fluids collect into the ducts, and then the ducts squeeze the fluid into the oral cavity. The ducts also alter the composition of the saliva. So that means if you're eating and you need your saliva to be more alkaline because there's an increase in acid in your mouth, that occurs within the ducts, not within the secretory cells themselves. So saliva is mostly water, 99.4%. So there is some inorganic components, calcium, potassium, sodium, phosphate, chloride, and bicarbonate. So I've talked with a few of you about where calculus tends to form. Okay, it tends to form most frequently on the lingual of the mandibular anteriors and on the buccal of the maxillary first and second molars. And that's because of the inorganic components of the saliva. Okay, so those two areas are where the major salivary ducts are, and that is where saliva tends to pool. So if saliva has a lot of inorganic components and it's sitting on those teeth a lot, it often will help to form calculus. So there's inorganic and then there's organic components, which are protein carbohydrate complex called mucin. There's some suspended materials that are just sort of in the mix, epithelial cells, oral bacteria, and yeast. And there's also an enzyme called amylase, and this actually helps with digestion. It begins to break down starch molecules into simpler carbohydrates. So secretion of saliva is controlled by the autonomic nervous system. Think autonomic, think automatic. Okay, you don't have to think about increasing your salivary flow rate. It happens with sensory input from the mouth and your environment. So autonomic nerves from the brain to the gland come from the parasympathetic division only. We're going to learn a lot more about this when we talk about nerves in a couple weeks. So nerves control the volume and type of saliva secreted Various sources can stimulate salivary flow. So think about what makes you salivate. Okay, does thinking about a food that you really like salivate, or smelling something delicious? You also tend to increase your saliva flow when you feel sick and you're about to vomit, right? You get that salivary flow first. Salivary flow also decreases when you're sleeping. So, what is the pH of saliva? This is the saliva plays a big role in caries and reducing caries. So the normal range of saliva is from 6.5 to 7.4, which is considered neutral. So with increased saliva, which would happen during and after eating, the pH becomes more alkaline or basic. And that's because when we're eating, we have more acidic pH being secreted from the composition of our plaque and the food that it's interacting with. So the alkalinity actually counteracts the acidity that's being produced through eating. So if you recall from Concepts 1, you're learning that biofilm interacts with food, and that can create acid that causes caries within the mouth. So here's the acidity of common drinks. Okay, you can see water is very, very neutral all the way here at the bottom. Okay, water and sugar is neutral, and it gets more and more acidic as you come up. So tooth enamel starts to dissolve at pH less than 5.5. So we're starting at flat mineral water, okay? And anything up here, this can cause acidity that will cause tooth enamel to start to dissolve. So your saliva is constantly working against that. So the more episodes that you have of exposing your teeth to that acidity, the more likely you are to have caries, and the saliva can't keep up. So frequent sugar containing snacks between meals cause more episodes of the oral pH falling under 5.5, which of course increases caries risk. Fewer sugar-containing snacks between meals cause fewer episodes of the oral pH under 5.5. So when you take longer breaks in between meals, your saliva has more time to neutralize that acid. If you're constantly eating and snacking, the saliva doesn't have the time to neutralize that acid, and you're making yourself more susceptible to caries. So your salivary glands have two different types of secretion. There are serous cells, and they secrete more of a watery substance, a watery secretion that contains amylase. Other secretions are mucus. Other glands secrete mucus. Okay, and we all know what mucus is. It's thick and ropey with high amounts of mucin. So some glands have only one type. And the submandibular has both serous and mucus secretions. So you may notice an increase in mucus secretions when you are thirsty. Your saliva feels thicker. So what is the function of saliva? Why do we have saliva? So it maintains the body's water balance. Okay, it helps to keep you balanced in your hydration. It is also an indicator when you're low on saliva that you are low on water in your body and you need to rehydrate. It helps with deglutition or swallowing. So obviously just the presence of saliva lubricates the food and helps it move through your mouth and down into your digestive system more easily. Saliva also works to bind that chewed food into that bolus to slide down, and it protects the tissue from being irritated by the food, both mechanically and with the basic pH. So it also lubricates the oral mucosa when you're not eating. So think about someone who breathes through their mouth, and you'll notice this more as you see more patients. When you meet a patient that is a mouth breather, especially at night, that means that their mouth is open for long periods of time. So saliva is not cleansing and hydrating those tissues. So often you'll see very inflamed tissue, especially in the anterior region when you have someone who's a mouth breather. So, and saliva also functions in taste. There are molecules in food that are solubilized to be tasted by saliva. That's a tough word. So more functions of saliva, they protect the teeth. Okay, we've talked about how it neutralizes plaque acids. It also has a source of minerals for remineralization. It's a source of systemic fluoride. So fluoride that you ingest in your body comes out into your saliva and helps for remineralization. Fluoride also is spread throughout your mouth, topical fluoride through saliva. It's part of the self-cleansing mechanism that you learned about in histology. It helps to cleanse the teeth and wash them. And then you have lysozyme, which is an enzyme that lyses many bacteria. It breaks apart many bacteria, and it helps to prevent overgrowth of oral microbes. So you'll find when you have patients with xerostomia or not enough saliva, they'll have an increase in caries, and they'll have an increase in risk of periodontal disease. And saliva also initiates the digestion of starch, which we just talked about. So what is xerostomia? Xerostomia is a decrease in salivary flow, and it can have a lot of reasons, a lot of causes, okay? But it results in a dry mouth. So if your patient tells you that they have a dry mouth, it can be considered xerostomia. So and here's a picture of someone with a very dry tongue, okay, and it's probably pretty sore. So medical histories that may be related to salivary gland dysfunction. So what patients are at risk for decreased salivary flow? Someone with chronic sinusitis is susceptible to decreased salivary flow because they probably take antihistamines. Antihistamines dry your mucus production and also your saliva production. So you may notice if you've ever taken a decongestant that you feel very dry and you feel like you have to drink a lot of water. So someone with chronic sinusitis probably has a dry mouth very often. Current chemotherapy. Chemotherapy is a very strong drug that can decrease salivary flow. People who take antidepressants or take medication for hypertension, those drugs tend to cause xerostomia, as well as patients with diabetes. If you have a patient that has had head and neck radiation, so radiation treatments of any part of their head and neck, the radiation does actually have a necrotic effect on salivary glands. Lupus is an autoimmune disease that can cause salivary dysfunction. There's another another autoimmune disease called Sjogren's syndrome that decreases serous and mucus production throughout the body. Someone with recurrent oral candidiasis or rheumatoid arthritis are also likely to have xerostomia. So a patient is telling you their chief complaint. Some things they may tell you if they have xerostomia is that their mouth is sore or is burning, okay, because it's not being protected. They have dry, itchy, tired eyes. So often when the salivary glands are affected, so are the lacrimal glands. They tell you they need to suck on candies, and that's because sucking on a candy, something hard, stimulates salivary flow. They tell you they need to sip water throughout the day and night. They have difficulty speaking for more than 10 minutes or difficulty swallowing food. Okay, saliva helps lubricate all of those things. So are you ever nervous when you're speaking in front of a group and notice that your mouth dries up? And that causes it to be very difficult to talk. So these are some of the things someone with chronic xerostomia may tell you. So what kind of questions do you want to ask a patient to determine if they have decreased salivary flow? So we do check for salivary flow, right, when we do our intraoral exam. So you're checking those glands to see if they're working, but you also want to ask the patient some questions. So ask them, do you sip liquids to help you swallow dry food? So if they eat a cracker, can they swallow that cracker or do they need to drink water? Does your mouth feel dry when you're eating a meal? Do you have difficulty swallowing your food? And does the amount of saliva in your mouth seem to be too little or too much, or is it unnoticeable? So if someone doesn't have enough saliva, what do you think you're going to see in their mouth? Okay, so we know that saliva helps decrease caries risk by neutralizing plaque acid. Okay, so that means someone with chronic xerostomia is going to have an increased rate of caries, especially in cervical areas. Okay, and if they have exposed cementum, definitely. They're going to have more periodontal problems because they don't have enough saliva, they don't have that lysis going on of bacteria. They may have poor oral hygiene. Okay, if there's not enough saliva, there's not enough self-cleansing going on. Halitosis for sure, okay, because there's going to be an increase in bacteria in the oral cavity. And you're also probably going to see oral ulcerations and infection. When you're working on this patient with xerostomia, your mouth mirror is going to stick to their dry mucosa, and that's uncomfortable. So if you have a patient that has xerostomia, dip your mirror in, water or some mouthwash, not an alcohol mouthwash, an alcohol-free mouthwash, to keep that lubricated. You may see that they have frothy saliva, so their saliva might be thick and bubbly, but they have a lot of mucus secretion, but not a lot of serous secretion. So you won't see someone with xerostomia, you're not going to see the saliva coming out of those sublingual caruncles or the parotid duct there. You're likely to see oral candidiasis, which is a yeast overgrowth in the mouth. And you're also going to see a decrease in filiform papillae or glossitis, so that shiny, glossy tongue that I showed you a few minutes ago. So a very common cause of xerostomia is mouth breathing. Okay, and what are some of the cues? So most of the time, I don't even have to ask a patient to know that they breathe through their mouth. And what I see most often is inflammation around the maxillary anteriors, especially because when a patient is mouth breathing, their mouth is open at night, and those tissues on the facial of your anteriors get very, very dry. Okay, there's no self-cleansing, there's no pH balancing going on, so those areas are going to be inflamed and more susceptible to caries. So a question for you. Which of the following dental management methods is best for patients with decreased salivary production? Is it 1-year dental hygiene recare visits? Is it dietary management? Is it aerobic exercise? 3-month supportive dental hygiene care interval, or an electric toothbrush? So if I had a patient that had very decreased saliva or xerostomia, I would want to see them every 3 months because they are at high risk for periodontal disease, they're at high risk for caries, so I want to see them to make sure we're giving them as much care as possible. Other recommendations that you can make to someone who has xerostomia is, frequent sipping of water throughout the day, and make sure you say water. Okay, we don't want people sipping, Gatorade or soda or even coffee with sugar and cream. Anything that has any kind of sugar in it can increase caries risk. So sugar-free candies, sugar-free gum will both stimulate salivary flow. Also, there are products out there to help with xerostomia, and a product that you'll learn about and that we have sometimes in the clinic is called Biotine. Okay, so let's talk about the major salivary glands, and I think at this point you're pretty familiar with these. So the major salivary glands are the parotid gland, which is paired. They're all paired. The parotid, the submandibular, and the sublingual. So your major salivary glands, again, the parotid, and there's an accessory parotid gland, the submandibular, and the sublingual. So the parotid gland, we all know where it is. We palpate it during our extraoral exam. So it lies under the skin of the cheek in front of the ear. Okay, it's superficial to the posterior portion of the masseter muscle. The fibers from the facial nerve run through it but don't innervate it. So why is this important to us? If there's damage to the gland, or for some reason we accidentally anesthetize the gland, you'll have some facial paralysis. So the parotid gland drains through the parotid duct into the Stenson's duct. and the Stenson's duct lies just underneath that parotid papilla. So that's where we check for parotid salivary flow. So the duct, Stenson's duct, crosses the masseter muscle. Okay, you can see it comes across the masseter here, and then it pierces through the buccinator muscle right here. So, and it brings secretion into the mouth opposite the maxillary molars through the parotid papilla. So even though this is the largest salivary gland, it's only responsible for about 25% of all our serous secretions of saliva. The parotid gland, and this is just showing you how we palpate, and we all know that. The autonomic efferent nerves, which cause the saliva to flow, are innervated by the glossopharyngeal nerve, which is cranial nerve 9. The general afferent sensation innervation comes from the auriculotemporal nerve, which is a branch of the mandibular division of the trigeminal nerve. So we've all heard of mumps, probably because we've had a vaccine called the measles, mumps, and rubella, or MMR vaccination. So mumps is an acute viral illness caused by the mumps virus, and you don't see it very often because of vaccinations. So symptoms of mumps is fever, headache, muscle aches, tiredness, and loss of appetite, followed by swelling of salivary glands. So you can see this young man here has a very swollen face, and you can see his parotid gland is swollen, and it looks like probably his submandibular as well. But the parotid salivary glands are the most frequently affected. So now let's talk about the submandibular gland. So it's located inferior, anterior, and medial to the angle of the mandible, and you can probably feel yours right now. Okay, most of the gland is superficial to the mylohyoid muscle, but a small portion wraps around it. So here's the mylohyoid muscle here, and you can see this gland sort of hugs that mylohyoid muscle. So the submandibular gland excretes through the Wharton's duct, and you can see evidence of the Wharton's duct through the sublingual caruncle. So you'll see that right here. So it runs upward and forward from the gland. So the secretion of the submandibular gland is the one that is mixed, okay? It does both serous and mucus secretions, and this one provides the largest volume of saliva. 60 to 65% of the saliva in the mouth comes from the submandibular gland, as opposed to the large parotid gland, which is only responsible for about 25%. So innervation of the submandibular gland in the autonomic sense, or efferent, is from the chorda tympani nerve, the branch of the facial nerve, which is cranial nerve number 7. The general afferent is from the lingual nerve, in a branch of the mandibular division of the trigeminal nerve. So that's why when we anesthetize the lingual nerve, or the mandibular branch of the trigeminal nerve, we get numbness in the floor of the mouth and the submandibular gland. So here's an x-ray, and you're looking down, a radiograph I should say, you're looking down into the floor of the mouth. These are the mandibular teeth, and this is an example of a submandibular gland that is blocked with a salivary stone. So this can happen because the submandibular gland has that long Stenson's duct, Wharton's duct, and there's a lot of opportunity for the minerals in saliva to congregate and form a stone. So the stone actually can be sometimes what they say milked out of the duct. Okay, it can be pushed forward and pulled out, and that's what you're seeing. That's what you're seeing right here. You're seeing a stone come out of that submandibular gland. So here, when you have a swelling of that gland and a backup of saliva because the duct is blocked, that's called a ranula, and it would look like this. So now let's talk about the sublingual gland. So it's a little more anterior than that submandibular. It's located between the mucous membrane and beneath the mucous membrane in the floor of the mouth. It rests on the superior portion of the mylohyoid muscle. It sits sublingual in the sublingual fossa of the mandible and helps to form these sublingual folds. Okay, so you can see these submandibular gland would be back here. This is the sublingual, and here are the sublingual ducts. And Bartholin's duct, which is also comes through the sublingual caruncle there. So here's a sublingual swelling, okay, and that could be from a salivary stone. So again, sublingual gland is an excretory duct. It has two duct systems. The ducts are Rivinus, which is 8 to 20 small ducts along the sublingual fold, so right along here. And then again, the Bartholin's duct, which opens into the sublingual caruncle, or the right beside the Wharton's duct of the submandibular gland. Mostly, the sublingual gland secretes mucus. So the sublingual gland is innervated autonomic efferent with the chorda tympani, which is a branch of the facial nerve, which is cranial nerve 7. The general afferent sensation is from, again, the lingual nerve, which is a branch of the mandibular division of the trigeminal nerve. This is just a review of your major salivary glands. So here you have your parotid with your parotid duct. You have your submandibular and your sublingual. And in the sublingual, you can see those minor salivary ducts and then your major duct here. Okay, so take a look and see if you can identify the parts of this diagram. You can pause me for a second if you want to test yourself, and the answer is in the next slide. And here's your answer. I can't imagine you got any of that wrong. So we have a number of minor salivary glands throughout the mouth. They are much smaller in size, 2 to 5 millimeters. Each gland has its own duct that opens into the oral cavity. So the secretions are either serous or mucus, with one type predominating. And the function is to secrete small amounts of saliva to keep the entire mucous membrane of the mouth moist. So there's several minor palatine glands. They cover the posterior of the hard palate and the soft palate. And you see evidence of those. They're not really noticeable until you have something like nicotine stomatitis. Nicotine stomatitis is irritation of those palatine glands. There are lingual glands. So there's salivary glands right on your lingual surfaces, okay, your tongue surfaces. So you have anterior lingual on the ventral of the tongue. You have the von Ebner's glands, which are located in the groove around the circumvallate papillae. And then you have posterior lingual salivary glands located around the lingual tonsils of the tongue. So question, which of the following glands lies immediately inferior to the circumvallate papillae? So quiz yourself. And the answer is the von Ebner's glands. So there's also some minor salivary glands in your labial and buccal mucosa. And they're located just under the mucosa in the cheeks and the lips. So sometimes you get a little blockage of a minor salivary gland, and we call that a mucocele. Okay, and here's a small example of a mucocele. So it looks kind of like a balloon blown up underneath, a water balloon, I should say, blown up underneath the mucosa. It usually happens when there's some sort of trauma to the excretory duct. Okay, so moving past the salivary glands, we're going to talk about the thyroid gland. So you palpate this gland as well during your extraoral exam. It's located in the anterior of the neck, inferior to the thyroid cartilage. There's 2 lobes connected by the isthmus. It's a large endocrine gland, so that means that the hormone secreted, which is called thyroxine, hormone secreted into the bloodstream directly. A goiter is an enlargement of this gland. So you might see this just walking past people on the street. There's numerous causes. There can be hypo and hyperfunction of the thyroid, and it can cause a goiter. Most common worldwide cause is a dietary deficiency of iodine. So here's your thyroid. Okay, we're all familiar with this. So here's your thyroid cartilage, here's your hyoid bone, and here's your thyroid. So here's your left lobe of the thyroid, the right lobe, and then it's the isthmus in the middle. So here's what a goiter looks like, and some are big and some are small. So this lady's is not terribly large, but you can see the enlargement in this area of her neck, and hers seems pretty symmetrical. Oops, I didn't mean to do that. So here's a larger goiter, and it's really bulky right in the middle. And you can see this is an even larger one, and it's more asymmetrical. Okay, so these are all evidence of thyroid dysfunction. This is a very clear thyroid enlargement. You can actually see that thyroid. So what does a thyroid hormone do? It has everything to do with metabolism. So more thyroid hormone increases your metabolism. It helps you regulate the catabolism of protein, fat, and carbohydrate. So how you use those. So if you have hyperthyroidism, that means you metabolize those things faster. So someone with hyper might be very skinny and have a lot of high energy, high heart rate. Okay, someone with hypo doesn't metabolize very well, may feel like they keep weight on that they don't want or know how they have lower energy. So thyroid hormone helps maintain normal growth and development. It affects body temperature, cardiac output, so whether your heart rate is high or low, and it also influences muscle tone. The parathyroid glands are not palpable or visible extraorally. They're located on the posterior of the thyroid gland. There's 4 small glands. They are also endocrine glands that secrete parathyroid hormone, which regulates your calcium and phosphorus levels in your blood. So this regulates your absorption of calcium, your storage and removal of calcium from bones, and excretion of calcium. So in here is you're looking at your parathyroid glands, but you're looking at an anterior view, but they're on the back side of the thyroid. So this is looking at the thyroid from a posterior view, and here's your little 4 parathyroid glands. We also have the thymus gland, which we also do not palpate. It's located beneath the upper end of the sternum in the lower anterior region of the neck. It's also an endocrine gland, and it has a lot to do with immunity. So T cells of the immune system develop in this gland and then migrate to the lymph nodes in the spleen. So this is a gland that is prominent in childhood and decreases into adulthood and shrinks. And lastly, we have the lacrimal glands. So we have studied where those glands are located. And they're located to either side of the eye. And here's your lacrimal gland and your lacrimal excretory ducts. And then over here you have your nasolacrimal duct, which helps to drain the lacrimal fluid into the nasal cavity. So lacrimal fluid is secreted onto the eyeball to lubricate the eyeball and the conjunctiva. So in review, here is an example here's a little case study. So this is a 54-year-old male who smokes and drinks and has this firm mass for at least 5 years. It's asymptomatic, slow growing, and it's in the parotid area. So this is a benign tumor of the parotid gland. Here's a ranula. Okay, your patient lifts up their tongue, or it feels like they have a mass under their tongue, and you see this. Again, that water balloon look. Okay, this is due to a blockage of the drainage of the saliva into the oral cavity. So often there's a stone that's blocking that duct. Okay, so why don't you quiz yourself? See if you can identify the things in this picture, and feel free to pause, and then your answers will be on the next page. And that concludes our presentation.